Ladies and gentlemen, please welcome Audra to the stage.
Hey there, everybody. How are you? How were you last night? Even better? That was so much fun. I hope everybody got a chance to join us. I know I did. It was really great. I know there's some disgruntled people in the audience. I'm not going to look up that did not apparently place where they thought they should in the costume contest. But I am going to bring Katie Dugan-Vargas up so that we can have a little recap before we get started. Katie says I threw her under the bus because I told everybody that she picked the costume winners.
All I gotta say is I had help from some of my lovely staff members over here, so. Did y'all have fun? Yeah! That doesn't sound like y'all had fun. Y'all need more coffee. Did y'all have fun? Yeah! That's what I'm talking about. So as some of you may remember last night, we had some really amazing, just top-notch costumes this year. So much so that we really had to break it up into some categories because usually it was all together. So this year we had an individual category, we had a duo category, and we had a group category. So to recap, for the individual category, I had to flip it over. I was going to announce it wrong. Should I go first or third? We'll start with third. We'll start with third place. And I want to be clear. I want to be very, very clear. Let me be clear. Every person is a winner in our eyes. Yes, you are all winners. And every person that won this year won free registration for our 2019 conference in Seattle, Washington. So very exciting. So in third place, in the individual category, a top-notch winner, might I add, we had Miss Robin Cohen from the Sandy Roman Ovarian Cancer Foundation. She was our peacock. In second place...
She's always a winner in our eyes.
Yes. Much love, teal love. In second place, we had our teal cowgirl, Miss Bonnie Taylor. And in first place, we had the fabulous Miss Annie Ellis with our notorious Ovarian. And in our duo category, we had from the land down under, give it up for our girls from Australia. They were the Ovarian Cancer Ribbon. In second place in the duo category, we had our Alabama survivors with Miss Susan Layton. Oh, did I went backwards again. I said first and I said second. And so in third place, like I said, everyone is a winner. We had our favorites from the Teal Diva. And then in the group category, it was just so many to pick from. So we actually added an honorable mention. And for honorable mention, we had the Norma Leah Foundation. And in third place, all the way from California, we had our Chef Ladies with Dee Mitchell. In second place, from Cincinnati, we had our Wonder Women. And in first place in the group category, give it up from the girls all the way from Louisiana, we had our Voodoo Girls. And again, everybody was a winner, and we so thank you for participating. And if you didn't go all out this year, you might want to think about it for next year. We'll be there.
Thank you, Katie, and thank you for your enthusiasm so early in the morning. But and also last night, I will say it was so much fun, and a lot of that is Katie. She put so much into that party, into picking everything. And now I am very pleased to announce one of our most popular sessions, which is the Ask the Experts. And today we have three wonderful panelists with us who will be taking your questions. We have Dr. Anil Sood, Dr. Amanda Nickles Fader, and Dr. Susan Modesitt with us today. So join me in welcoming them. I just wanted to note also that the panelists can't answer specific questions, but personal questions, but they certainly are willing to take any other type. So please write them on the cards. We have volunteers circulating throughout the room, and I know we've been collecting them. So we're looking forward to a great session. Dr. Sood will be moderating today, and he is professor and vice chair for translational research at the Department of Gynecologic Oncology and Reproductive Medicine at UT MD Anderson Cancer Center. He holds a joint appointment in cancer biology and is co-director of the Center for RNA Interference and Non-Coding RNA at the MD Anderson Cancer Center. He's also director of the multidisciplinary Blanton Davis Ovarian Cancer Research Program and co-leads the Ovarian Cancer Moonshot Program. He received his medical degree from the University of North Carolina, Chapel Hill. A major and consistent theme of his scientific research has been on understanding human cancer biology and converting lab discoveries into novel therapeutics. His research group has made several seminal research contributions in the fields of tumor microenvironment, nanomedicine, and neuroendocrine efforts on cancer biology. I'm pleased to welcome Dr. Sood and our other panelists. Dr. Sood will be our moderator today.
Well, good morning, everyone. And first of all, thank you to all the winners this morning. It's really wonderful to see. So
We wish we had the pictures, though.
Okay.
So it's really a pleasure to help to chair this session. Along with me is Dr. Susan Modesitt, who's the Director of Gynecologic Oncology and Director of the High-Risk Breast and Ovarian Cancer Clinic at the University of Virginia. She has an endowed professorship, the Richard and Louise Crockett Endowed Professor in OBGYN. Along with her is Dr. Amanda Nickles Fader, who is an associate professor at the Johns Hopkins Medicine Department of Gynecology and Obstetrics, and she's both the director of the Kelly Gynecologic Oncology Service and the director for rare gynecologic cancers at Johns Hopkins. So what I thought we would do is I've tried to cluster the questions. There were some questions that had similarities, so I tried to group them together. One of them I wanted to just actually bring up really quick. There were 3 questions actually related to will the slides from the will they be available to the attendees? And I asked Sarah about this earlier as well, and she mentioned that the slides from the other presenters throughout the meeting, they'll be available at the website, and they can get you the website address and so on afterward as well. So with that, why don't we go ahead and get started, and we'll alternate between the 3 of us in terms of addressing the questions. So one of the questions was, why has the incidence of ovarian cancer diagnosis been decreasing? It used to be 1 in 72, now it's 1 in 79. So Amanda, will you take this?
Sure. Hello, everyone. Good morning. It's a pleasure to be here. Thank you for having us. So it's, I think, a very exciting time in gynecologic cancer and ovarian cancer research and treatment in general. And I think that the reason that we're seeing initially very modest decreases in ovarian cancer incidence and now greater decreases is multifactorial. For those of you who may not have read, the American Cancer Society came out with a recent bulletin about 2 or 3 weeks ago showing that for the first time in 30 years, the incidence of both ovarian cancer is decreasing and the survival rates were significantly increasing. And I think we can attribute this to a variety of factors. We're not entirely sure which one factor is making the most difference, but better access to gynecologic cancer experts and more experts available. We know that going to seek treatment from a medical oncologist or GYN oncologist who specialize in ovarian cancer is very important. Better surgeries, better and more tailored personalized treatments, including the advent of different dosing schedules for chemotherapy, PARP inhibitors, et cetera. And then from a population-based perspective, we're learning a lot about where these cancers originate and that many may start in the fallopian tube, some start in the ovary, and so utilization of oral contraceptives really help reduce the incidence of ovarian cancer, removal of the fallopian tubes in high-risk women, and even we're looking at this in low-risk women in many countries to overall decrease. And so I think we're going to start seeing some major gains and decrease.
One additional thing is we have figured out that a lot more ovarian cancer is hereditary than perhaps some other cancers, and so we're able to identify families and women that are at the highest risk and then implement some of these risk-reducing strategies much earlier than we have before. So I think it's a multifactorial. A lot of these things are coming together. It's not where we need it to be yet, and so that's why all of us are still focused on trying to do these things.
Along those lines, to build on that, Dr. Modesitt, how important is it to have genetic testing, and even if it's been done before?
Yay, I love it when I get softball questions. I hate the hard ones. I make Anil answer those. So just in case, I'll put in 2 plugs. Amanda is going to be doing a rare ovarian cancer session, and I'm also going to be doing an hour hereditary session. So we'll be doing deep dives into both of these topics. I think it's incredibly important to do genetic testing, and the rules have been changing rapidly. Okay, so if you had genetic testing, for example, in 2006 or in the 1990s, back when I started training, you would have only gotten BRCA testing, and we're finding a lot more things. And even if you got BRCA testing in 1991, up until 2011, there were still reiterations and better testing and identifying more people. And then panel testing, where we've got some of the more rare genes that may have an impact, it just started really coming out in 2013, and every time I turn around, there's a new one. So what I would recommend for anyone who has had ovarian cancer, you should have genetic testing, and we'll talk about the specifics of that later. And if you had genetic testing before 2013, it might be worth talking to your cancer specialist about whether there might be something more additional if you didn't have a positive test.
Okay. So there's a question, why can't you drink orange juice or grapefruit on PARP inhibitors? So this relates to that grapefruit and actually certain other types of citrus like Seville oranges can interfere with an enzyme that helps to metabolize these and other drugs. And with grapefruit, even if it's been a few hours since the grapefruit, it can actually interfere with this enzyme, so the drug levels can go up quite a bit higher. So it results in inconsistent or elevated levels of the drug, which can then cause toxicities and so on. And that's really the main reason why we recommend not taking grapefruit along with the PARP inhibitors. And as I mentioned, there are many other drugs like that. So it's a good idea to check with your physician or with a pharmacist in terms of what kind of drug or even drug-food interactions that might occur to avoid those kinds of problems. Next question for Amanda. Should a patient with low-grade serous ovarian cancer stay on continuous hormone therapy? What about the 5 versus 10-year treatment period, especially with side effects and so on?
Okay, so this is a topic near and dear to my heart. I study low-grade serous carcinoma and the use of hormone therapy. And to clarify, of all of the more common types of ovarian cancer, serous is, how many of you in here are familiar with the serous ovarian cancers? Yes, so serous high grade is the most common, and then low grade serous is also one of the subtypes. It occurs in about 10% of women. And the great thing about the low-grade serous carcinoma tumors is that they express in about 80 to 90% of all tumors estrogen and progesterone receptors. And these are estrogen and progesterone are hormones that our ovaries produce, and these receptors are little proteins on the outside of the tumor cells that we can target for treatment with anti-hormones. So we can use antibodies that target these receptors, things like tamoxifen and the aromatase inhibitors like letrozole, Arimidex, things of that nature. And so in many cases, either when a woman is newly diagnosed after surgery with or without chemotherapy, or in the setting of having a relapse of the cancer, hormonal therapy is utilized for women with these types of tumors. And in my practice, we keep women on hormone therapy. We usually start with an aromatase inhibitor like letrozole and anastrozole. And these are pills that are taken usually once a day and overall have pretty good a side effect profile compared to chemotherapy. And I like to keep my patients on these hormonal therapies for as long as possible. So indefinitely, as long as the tumor hasn't progressed or grown significantly, or one of my cancer survivors, patients has not had incredible toxicity or side effects from the drug, in which case then we can often switch to another hormonal agent with fewer side effects.
Can I say one thing? Just people use hormonal therapy to mean a lot of different things. So there's hormone replacement therapy, where you're getting replacement of estrogen and progesterone, which can be appropriate in certain cancer survivors, okay? And then there's anti-hormonal therapy, which is also called hormone treatment, but those are tamoxifen, which are estrogen blockers, and then the aromatase inhibitors. So just be careful when you're saying hormone therapy, because it means different things to different people.
Susan, what is the status of research on finding an early detection screening test for ovarian cancer?
Thanks, Neil. I really like that question. So as many of you, I'm sure know, this has been, as I call it, and I love Monty Python, this has been the holy grail of ovarian cancer for as long as I've been alive. And the issue is, we know that some people are stage 1. If we found everybody in stage 1, we have a 95% cure rate. The problem that we have, and Amanda alluded to this earlier, is that we think a lot of ovarian cancer might actually not be from the ovaries. It could be from the fallopian tube. So you get these tiny cells that become abnormal, precancer, cancer. They get exfoliated out into the abdomen as itsy bitsy tiny cells, and so we can't see them on an ultrasound. We don't pick it up on a CA-125. If you name a tumor marker or any protein, we've looked at it for ovarian cancer, and nothing has yet outperformed the CA-125 as a single entity. So now that we're getting more and more molecular type testing, we're starting to look at other ways to look at it, because of our traditional ways really haven't worked very well. And so now there's ways to collect cells out of the cervix, out of the fallopian tube, and start looking for these minute genetic harbingers of potential cancers. So this is all what we're working on now. I mean, all 3 of us at our programs have programs looking particularly at this. We've got a whole registry collecting tampons from people, from collecting cervical. I know. We call it the tampon study. It's a crowd pleaser. We do other stuff too, but that's all anybody remembers. So we're super creative in medicine. Sorry. So again, there's a lot of stuff coming forward and a lot of work being done on this, and they can probably expand on their own programs. So I hope we're going to start really having a better way to identify these precancerous changes before all of these events transpire. So there's a lot of exciting stuff going on, and I'm sort of hopeful that we're going to do something good with this in the next 5 to 10 years.
I think that to add to that, because these tumors are so difficult to pick up in an early stage with the existing commercial tests like ultrasound and CA-125, looking at things on that molecular genetic level, either in the blood, in the tampons. We have a PAP called that. We have the PAP gene, a little sexier than the tampon study. Oh, I'm just kidding. But I'll be talking a lot more about that actually in the rare tumor session with personalized genomics and some of the early screening tests that are and platforms that are being developed at Anderson, UVA, Hopkins, and some other centers. Because we are, despite the challenges, we are starting to make some major gains in how to approach detection of this cancer.
So there's a question about when would second-look surgery be an option? When I was in training, when in fellowship, we used to do a lot of second-look surgeries at that time, and it was a little different time because they were all done with an open incision, with a big incision. We stopped doing them in the late 90s, partly because there was no real benefit to patients in terms of survival outcomes. And a lot of the treatments at that point were somewhat limited. They were mostly chemotherapy-based, and we tried even putting one of the last trials that we were involved in, put in something called P32, which was a radioactive substance that was put into the abdomen And unfortunately, it just resulted in more toxicity rather than in benefit. So at that time, we stopped doing it. However, now we're at a very different point in time. And we're actually having a lot of discussions about doing second look surgeries again, and doing it in a different way, doing it with minimally invasive surgery so that you don't have to make a big incision. And then moreover, so far our feeling is that as long as there's something that can be done for every woman who would take part in it, so to do it as a part of a clinical trial, and regardless of the results, whether it's negative or positive, have something available. So those women who have a negative second look surgery still have a significant risk for relapse disease within 18 months. So if we can implement immune therapies, vaccine trials, things like that, that would be an opportunity. And then those who have a positive second look surgery, again, the types of molecularly targeted drugs that are available now is very different than 15, 20 years ago. So we have, on a clinical trial, started to do second look surgeries again as of about 6 months ago. And as a part of our SPORE network, we're talking to other institutions as well to see if they would be interested in starting to do those kinds of clinical trials. So it is an opportunity. We have to move forward carefully and cautiously and do it in a way that has a potential to help women who have these kinds of surgeries.
Anil, can I say one thing about that?
Sure.
The hard part is just because we can do something doesn't mean we necessarily should. And that's why Dr. Sood's being so careful about doing this as a clinical trial, because the hard part is if you know something might happen, but you're doing something that won't help, it just adds toxicity. So, a phrase I use a lot with my patients is, I can't make an asymptomatic patient feel better. Okay, so if you're not having symptoms and you're not having problems and you're not on chemo, anything I do to you is going to make you feel worse. And so I should only be doing something if it's going to change and improve your outcome. So just, we always like to do something. I mean, I'm a surgeon, I like to do things. So we always have to think, are we doing the right thing? And so that's why it's so important that we really look and do it in a systematic way and compare folks we do stuff to versus folks we don't do stuff to, and make sure that there is improvement. Sorry, I'll get off my soapbox now.
I mean, if letrozole fails to be effective in treating someone with recurrent low-grade serous cancer, do you try another anti-hormonal therapy?
That's an excellent question. So what we like to do at our center, I think many centers are doing this if letrozole stops working in a woman where it previously worked. So we do tumor testing for a specific mutation in the tumor. It's called ESR1, or estrogen receptor alpha 1. And we know that certain types of mutations, so DNA defects in this particular area of this gene, may lead to resistance to letrozole and other drugs in its class. And we know this from the breast cancer literature, and also we're starting to study this in ovarian cancer. So depending on what type of mutation we have, we still have many other options, some of them hormonal in women. We have other types of hormones such as tamoxifen, exemestane, fulvestrant, that work at different aspects of inhibiting or blocking hormones that we can use. And we have used some quite successfully, actually, in women who have stopped having a response to the letrozole. And then sometimes we consider targeted treatments, such as Avastin or other chemotherapy options. So there's still a lot of options. And in some cases, a clinical trial may be the best option for a patient in that setting.
Susan, why are oral contraceptives considered, so birth control pills considered, to help reduce risk, and other contraceptive methods not?
So we have the most data on oral contraceptives because so many women have taken them. We can look at big population studies. So the way we think they work is not 100% clear. It's probably one of those lovely multifactorial, which is doctor speak for we don't really know. There are a couple of mechanisms that we assume. One, we do know that the more times you ovulate as a woman, the more your risk goes up for ovarian cancer. I mean, not tremendously, but it does go up. So birth control pills block ovulation. They also impact how much your hormones fluctuate and go up and down, so they can act through that way. For example, for these low-grade cancers that are more hormonally active, having your levels a little bit lower than normally premenopausal may help. They may improve inflammation and things like that. So there are a lot of different mechanisms. As for the other hormonal type birth control, we just don't have as much data. We think maybe, for example, the patch forms of birth control pills that have both estrogen and progesterone, as well as perhaps the NuvaRing, which is a ring that has both estrogen and progesterone, might work equivalent to birth control pills, but we just don't have enough long-term data to be able to say that for sure. With regard to the IUDs, the progestin only IUDs definitely reduce the risk of endometrial cancer, that lining of the uterus. Progesterone is a natural hormone that kind of counteracts estrogen, so it makes things kind of shrink up a little bit, so it probably improves endometrial cancer. Not enough data to suggest that it does or does not for ovarian cancer, and maybe a tiny little very flawed data that the progesterone IUD might slightly increase breast cancer, but don't write home about that too much. So the other ones may do it, and if I have in my cadre of women that I'm following that are high risk, if I have a 25-year-old woman that is super high risk and I want her on birth control pills, but for whatever reason she can only tolerate one of the other types of things, I'm fine to use that. So I hope that answers it, whoever asked.
And just one other component, that tubal ligation as a non-hormonal mode has also been shown to reduce the risk for ovarian cancer. And part of the reason that may actually be is that now it's thought that many ovarian cancers may not necessarily start from the ovary itself, but rather the far end of the fallopian tube. And the mechanism isn't completely clear, but there is fairly consistent data about protective effect of tubal ligation. There are a couple of questions related to the role of laparoscopic or minimally invasive surgery versus open surgery. So this is obviously a very broad topic. So I thought I would just mention a couple of things. As a part of our moonshot effort about 4 years ago, we started to, rather than just doing an upfront open surgery on everyone, those who would be candidates for surgery, we've started to do laparoscopic assessment up front, which requires 2 ports where we can look inside and take a look at 7 different areas within the belly and pelvis, and then actually assign a score of 0 or 2 to each of those areas. If the score suggests that the surgery has a good likelihood of being successful, meaning that the GYN oncologist can remove all cancer, then we move forward with upfront debulking surgery. And in that setting, our success rate, now having treated over 600 women with this approach, has been close to 90% in terms of being able to resect all visible or palpable cancer. This will be reported within the next 2 to 3 months. It's been accepted now. And then those patients where the laparoscopic assessment shows that there's really no feasibility of being able to remove all cancer, then we typically give neoadjuvant chemotherapy, neoadjuvant meaning giving chemotherapy for 3 to 4 cycles, and then do the interval debulking surgery. And in that setting, where even though up front we couldn't remove all cancer, at the interval setting, about 80% of the times we can remove all visible or palpable cancer. So it just allows for a much more personalized surgical approach. Now, I get it that not all centers do this, but there are increasing number of centers worldwide that are starting to take this kind of a personalized approach. Another place where minimally invasive surgery perhaps has a role is in the second of second look surgery, which we already talked a bit about. So there are many other settings where it may play a role, but one cautionary tale that I just tell to the broader community as well, to gynecologists, is that try hard to not rupture the tumor, to try to remove it intact, even if they're attempting to do a minimally invasive surgery. Sometimes people get in the mindset that they have to do it no matter what as a minimally invasive approach, and it can result in harmful effects to women in terms of rupturing tumor and so on.
It is in some cases impossible to remove a tumor without rupturing it, whether open or laparoscopic, and some types of tumors that are quite stuck to other organs or to the side of the pelvis. But I absolutely concur with everything that was said. And another role that we utilize, and I think probably all of us utilize for laparoscopic surgery, sometimes in the setting of known recurrent disease, if there's one or two sites of isolated disease and we're not sure whether we can successfully remove them or we want to remove them and then move on to chemotherapy, starting laparoscopically in upwards of 30 to 40% of cases, one can do those resections laparoscopically, and then that interval to getting to the next phase of treatment is a little bit shorter with potentially better quality of life. But the most important thing is removal of all of the grossly visible disease, however that needs to happen, if that's possible to do.
Laparoscopy is a tool, okay, like any other tool we have, and sometimes it's appropriate and sometimes it's not. But it's a great thing to have in our armamentarium, and especially for you all, because it's easy for me to do a laparoscopic or an open surgery. I don't have the post-op care. So that's the whole benefit of the laparoscopic surgery, is quicker return to function, even though long-term outcomes are probably equivalent.
Man, if a histology is rare, such as clear cell, does that mean high risk?
It's a great question. Not necessarily. So some rare histologies are associated with, longer survival than some of the not so rare histologies. In fact, we're learning a lot about clear cell carcinoma, and that the early stage clear cell tumors, many more women may present with early stage clear cell carcinomas than some of the other subtypes, because these tumors can grow much larger in some cases than some of our other types of epithelial ovarian cancers, and so a woman notices the symptoms sooner and brings them to the attention of her healthcare provider. But we're learning a lot about clear cell now, and in some cases of early stage disease now, we are not always consistently using chemotherapy in that subset of women, and some women do well for a very, very long time due to the advances in ovarian cancer care. So having a rare histology just means that there's fewer women that we can study to define the optimal treatment strategies. However, we're making great strides with that. We used to lump all of the rare tumors, or women with all the rare tumors, into trials with women with the not so rare high-grade serous tumors. And now at the level of the National Cancer Institute, the NRG, the Gynecologic Oncology Group, and many of our centers, we're now splitting out women into their own trials for low-grade serous, for clear cell, for mucinous, for high-grade serous, so that we can appropriately study these women and their tumors and arrive at a more personalized, potentially targeted therapy that will lead to better success for them.
Susan, there were a lot of questions about PARP inhibitors. So I'm gonna try to group 2 or 3 of them now, and then we'll try to come back to those as well. So Susan, if you can briefly just address some PARP inhibitor questions related to, do PARP inhibitors cross the blood-brain barrier? And are PARP inhibitors a form of treatment or maintenance therapy? And if you use one PARP inhibitor and it stops working, can you use a second different PARP inhibitor?
I did this on purpose.
Okay.
Good. All right. I honestly have no idea if they cross the blood-brain barrier. I would have to look it up.
So the one that's thought to have some cross over, but again, this is not definitive data, is a PARP inhibitor called niraparib, which we tend to favor sometimes if there's presence of brain metastasis.
I know. All right, and I hate niraparib. Because each of these, there are 3 different PARP inhibitors. I love niraparib, sorry. But they're each used in a different setting sometimes, because, for example, niraparib may cross the blood-brain barrier, but also is a little bit harder on platelets. So it's one of those things, if I have someone that's got platelet problems, I definitely don't want to put her on niraparib. So you have to watch that. And they each have a little bit of different side effects. Is it form of treatment? It is a form of treatment, okay? It treats women's cancers through a particular mechanism around DNA repair. It works better in women that either have a somatic, meaning there's a mutation within their tumor, like a BRCA1 or BRCA2, or some of these other mutations that impact how the body can fix these DNA damage repairs. So these PARP inhibitors work much better in women that either have somatic or germline, meaning they were born with a mutation in BRCA1 or 2, but they do have some activity in women even that don't have that. So we kind of used to, when they first came out, we could only give them to women with a germline mutation. Now they're open for everybody. And in terms of, it is a form of treatment, and you can either use it as a treatment to treat some active disease, or once you've had someone have a response to a treatment, you can use it as a maintenance. As a definition, maintenance therapy means you have completed a therapy, okay, and then you're on something to hopefully either continue stable disease or continue in remission, okay, so to prevent disease from growing. That's what maintenance means. The question about if you have progressed on one, how much activity do you have in a second one? We're just starting to look at that. They all work through the same mechanism, so kind of similar to if you were on carboplatin and you progressed on that, would you respond to cisplatin or oxaliplatin, which are also drugs? Or if you were on paclitaxel and you progressed on that, would you respond to docetaxel, same type of drug? And the response rates following progression on one type of treatment to another in that class of drugs is generally relatively low, but it might be something that someone would pursue. I don't know if you guys have any other thoughts on that.
There will be other questions that will bring more topics up. I'm going to take 3 questions related to Highback therapy. So Highback basically means heated chemotherapy that's put inside the belly as a part of the treatment. There was a clinical trial that reported from France this last year that got a lot of press and a lot of attention as well. It's a bit controversial, and at this point, Highback as a routine form of therapy for ovarian cancer certainly would not be used. There are many issues related to this form of treatment, and I'll just very briefly mention some of those and perhaps a path forward. So the idea is that you heat up chemotherapy to about 42 degrees, and then you put it inside the belly for about an hour to 2 hours, depending on how you do it. The issue is that if you...
Celsius.
42 degrees Celsius, that's right, yeah.
Yeah, just making sure everyone knew. Hot, it's hot.
The issue is that, unfortunately, at the tumor site, you don't really get to those kind of temperatures at all. You don't even get close to those kind of temperatures. Every clinical trial that's been done so far, unfortunately, has had the wrong comparison group, where they don't really compare giving intraperitoneal chemotherapy at the normal temperature versus giving it at the warmer temperature. They all will compare either to no therapy or they'll compare to giving IV therapy. So it's not really a balanced clinical trial. There are 2 other clinical trials that actually don't show benefit from Highback therapy, so it's an area that still really needs to mature. At MD Anderson, where Highback therapy is used quite a bit, is in patients with mucinous types of cancers, where they will do fairly aggressive debulking surgery and then put in chemotherapy at a heated temperature afterward. But again, it's an emerging field. There are lots of limitations. It has to be developed carefully for it to be adopted further for routine treatment and so on. Amanda, so here's a broader question. When cancer recurs, why would the treatment be chemotherapy versus angiogenesis inhibitor versus PARP inhibitor? So what kind of settings, perhaps? You could talk about platinum sensitive.
Sure. So when we think about treating a woman in the setting of cancer recurrence, we've learned a lot over the last 2 to 3 decades about how to really tailor and personalize that treatment. And so it's a little bit of a difficult question to answer because there's so many potential scenarios here. But we generally try to classify high-grade serous ovarian carcinoma or any of the epithelial ovarian cancers as platinum sensitive or platinum resistant. are they likely to, is a woman likely to respond to a platinum agent, so carboplatin, cisplatin, which is the major driver of good tumor response or the backbone of a chemotherapy regimen in ovarian cancer. And that has to do with how long a woman has gone between completing treatment and then experiencing the recurrence. And we generally like to say that although platinum sensitivity is defined as greater than 6 months from last treatment to recurrence, we're really learning much more about it. It's more like 12 months or beyond, 18 months, where we're really seeing the best responses if you're re-challenged with a platinum agent. And so in the setting of at least 6, 12 or greater months of treatment-free interval or remission, it makes a lot of sense to consider giving a woman another platinum agent, usually carboplatin, if she tolerated that well before, in addition to another agent. We know that what we call doublet therapy, or 2 drugs together in that setting, lead to better outcomes for women and longer survivals and longer periods of potential remission. And so we'll usually choose an agent like carboplatin and couple it with either Taxol again, Doxil is another choice, gemcitabine or Gemzar. And there are many different reasons why you might choose any one of those particular regimens. In the setting, and then in women who you may consider a maintenance PARP inhibitor or a maintenance Avastin in select settings, depending on the type of cancer a woman has and what regimen you choose. Sometimes we withhold the PARP inhibitors until later in the course, depending on the type of mutations a woman's tumor may have, or whether she has a germline BRCA mutation. But I tend to favor the PARP inhibitors over Avastin in women with the BRCA germline or BRCA mutated tumors. In a platinum-resistant setting, in that sense, utilizing a carboplatin again may not make sense. Sometimes we'll utilize cisplatin though in that setting and join it with something else like a gemcitabine or a Gemzar. Or you can consider single agent treatments in that population of women. So things like Doxil, gemcitabine, potentially coupling something like Avastin with another drug like Taxol or Doxil are also options. So the good news is we have a lot of different tools in the toolbox at that point for women to consider.
Susan, there were 5 questions about cannabis or marijuana, so I'm going to just again bring those together.
I always get the marijuana questions.
Susan, from your personal experience, no, just kidding.
Okay, a little
sorry.
disclosure here. DC public school grad. They started that scared straight thing in 4th grade, so I have actually never used marijuana. But it's legal now, so one of these days I'm having a brownie.
So what are your thoughts about, so the specific questions are, so when can marijuana be of benefit in terms of medically controlling symptoms? Mm-hmm. And would you like to see a FDA approved or NIH approved clinical trial using these kinds of approaches, either for treatment or for controlling symptoms?
Okay, so there's a lot to cover here, and I'll try and hit the highlights. So first of all, for symptom control, marijuana and the various components of marijuana, and there are a lot of different subsets that go into it. There are the cannabinoids, there's THC and all of that. For example, there's an anti-nausea drug called Marinel, which is made out of a component, and that is readily available for prescription. So marijuana has been associated with improved appetite, decreased nausea, and things like that. So there are some medical symptom control reasons to use it. In certain states, physicians can prescribe medical marijuana. In certain states, it's open to the public, so patients can prescribe their own medical marijuana. And actually, this comes up a lot. And I actually, unfortunately, was once on NPR, and I had to be very careful about what I said. University of Virginia, you gotta be careful. And so I asked someone in California. I said, "Well, what do you do if someone wants marijuana?" And they said, "Oh, here's what happens. I write a prescription, I hand it to them, and then it gets sent to them, and there's some teenage boy who shows up at their house and tells them what to do." I'm like, "Oh, okay, that sounds great." So in my personal practice, if my patients, especially in the recurrent setting, I'm pretty much a free-for-all type of gal. If it makes you feel better, I'm okay with it. So I actually, this isn't being taped, is it? Okay. So I have a little cadre of patients who use it, know how to use it, and so they've let me kind of link up my patients. So if I have someone that has asked me about, is interested in it, then I refer them to one of my other patients that is using it, and then they work it out together. And then they tell me what they're doing. Then in healthcare stores, the whole other question is the anti-tumor effect of marijuana. And unfortunately, we really have not been able, for a lot of regulatory reasons and other reasons, to really investigate that as fully. So right now, my party line, I'd be interested to see what everybody else says, is that for symptom control, I'm perfectly fine with people using it. I'm pretty open to anything marijuana, acupuncture, anything that, again, I know doesn't have much harm and that makes people feel better. I'm a big fan of. In terms of the treatment anti-cancer, I believe the jury is still really out on that, so I can't comment on that.
I'm going to take a couple of questions related to, actually there were 4 questions related to different aspects of immune therapy. These include vaccine trials. These include why do some cancers with more mutation respond to immune therapy, and so on. So let me just take this at a broader level, that immune therapy for many different types of cancers has truly been a game changer. So if you look at, for instance, patients with advanced melanoma, certain types of lung cancer, renal cancer, and so on, there have been really remarkable responses seen. Now, within ovarian cancer, if you look at high-grade serous ovarian cancer specifically, the responses to immune therapy haven't been as substantial as perhaps we had hoped, and there are many reasons for that. When you look at ovarian cancers, a lot of the cancers don't have as many immune cells that have infiltrated into the tumor, so there are clear barriers that prevent immune cells from entering or surviving within these cancers. And so there's a lot of work being done to figure out how do you promote immune cells getting into the tumor so they can kill off the tumor. And there are some interesting studies that are being done, but again, these are early at this point. There were questions related to both vaccine trials and also engineering T cells, which is a form of immune cell, and then being able to give these. Some of the initial clinical trials suggested that when you re-engineer T cells and put those back in, compared to, for instance, patients with melanoma, in women with ovarian cancer, within a month, most of those T cells were gone. They unfortunately just didn't persist. And some of this very likely occurs because the cancer, these tumors are producing factors that can destroy T cells. And until we fix that side of it, it'll be hard for some of the conventional immune therapies to work. And then for vaccines, again, there's some early data to suggest there may be vaccines that may have interesting responses, but it really needs to be developed much better. Now, why do certain cancers with a lot of mutations, why do immune therapies work? Well, the body may already start to recognize some of these as foreign antigens so that you start to generate somewhat of an immune response. And if you can exploit that and take off some of the brakes for the immune system, that will work better. Now, the final thing I want to mention is there are some subtypes for ovarian cancer, such as clear cell or endometrioid forms of ovarian cancer, where you can see some cancers with something called microsatellite instability. Well, now there is an FDA-approved checkpoint immune therapy that can be used. That doesn't even have to be tested in clinical trials if that particular condition, the microsatellite instability, is present. That just got approved a few months ago. So in a sort of a broad setting, I would say immune therapy is clearly important. It hasn't worked as well as we would have hoped against ovarian cancer, but that doesn't mean we give up. There's a lot that can be done to help immune therapies work better as we move along. And some really exciting data to suggest that PARP inhibitors along with immune therapies may combine particularly well in ovarian cancer. So we really look forward to those kinds of studies being finished and get done. Sure.
Something to that. One of the things we learned about a lot of these newer, sexier targeted drugs like Avastin or PARP inhibitors, cediranib, and immune therapies is that they often will work better when utilized with other drugs. And we're learning that a lot with ovarian cancer, where the immune therapy agent may not work so well on its own. When it's coupled with another drug, it can activate the tumor, stimulate the immune environment so that those T cells, which are like our Department of Defense in the body, the helper and effector T cells are like our frontline defense, really recognize those tumors as foreign and go on the attack mode. And there's several clinical trials right now in the pipeline looking at the combination of immune therapies. And one of them actually, which combined a VEGF inhibitor, which is cediranib, which is like Avastin, with one of those immune therapies, saw really high response rates actually in high-grade serous ovarian carcinoma patients. It's a small group of patients of only 12, with only 12 women, but we're excited about those possibilities, about those combo strategies. So we'll hear more about that in the next few years.
Amanda, what are some of the new drugs or trials being developed for granulosa cell tumor and for low-grade serous cancer?
Thank you. So we just got hot off the presses. We just left the NRG and National Cancer Institute meeting up in Philadelphia earlier this weekend, and we are now in the rare tumor group starting to develop very specific trials for specific types of women with rare ovarian cancers. In the granulosa cell tumor world, work at MD Anderson and other centers are elucidating new pathways and new, what we call actionable mutations that we can target with specific drugs to improve outcome. And one of them actually that recently got approved and we hope will be moving forward in granulosa cell tumor is to study the combination of a drug that inhibits angiogenesis or new blood vessel formation around tumors, which is called cediranib, a drug I just mentioned, with immunotherapies in granulosa cell tumors. We know that granulosa cell tumors are very vascular tumors. They have a lot of new blood vessel growth around them and express these vascular growth factor receptors. And so there's also a mutation called FOXL2 that's been identified in granulosa cell tumors, and we're understanding those pathways. And actually one of the fellows at MD Anderson, Tyler, is studying those questions. In terms of low-grade serous carcinoma, we're very excited to report that we will be activating a new trial in the upfront setting, meaning at newly diagnosed patients, looking at the combination of chemo with hormone therapy after surgery versus hormones alone.
You've all been too chicken to do that.
Well,
until now.
Yes, so at Hopkins for the last 8 years, we haven't given chemotherapy up front. Call me crazy, I know, because it's...
We're glad you did.
Yeah, it was a little bit risky, but our patients have done very well in that setting if they had a high expression of those hormone receptors we were talking about. But there's also several exciting trials being developed in recurrent disease, including looking at MEK inhibitors, other hormonal therapy strategies, immunotherapy, and a pathway called the MAP kinase growth pathway in tumors that is, pretty activated in low-grade serous that we're targeting. So there's a lot of great treatment options on clinical trial coming forth for the rare tumors.
Thank you. Susan, there were 3 questions related to this. One was a very personal question, so I'm going to just frame it more broadly. So these questions relate to a diabetes drug, metformin. What role might that play for ovarian cancer? And second, if you can talk about sugar intake in cancer.
Okay, so I have 3 big research interests. One is hereditary, the second is obesity and its impact on cancers. And so the whole metformin, glucose, diabetes thing is very near and dear to my heart. So metformin is a drug that's used often for diabetes. And so when you look at cell lines, so you take tumor cells outside of the body, which takes away a lot of how it will really work, we found that metformin worked both by itself and in combination with other things to reduce growth. Okay, so that seems super exciting, a non-chemotherapy drug that might help. And so we've looked at it in a couple different settings, and in big trials. I always talk about all of us do research, and there's a great quote from Thomas Huxley that says, "The great tragedy of science is the slaying of a beautiful hypothesis by an ugly fact." And so many of us come up with these lovely hypotheses. We know in the cell line that this metformin works really well. If we add it in with some other chemo drugs, it works great. And so it works in the cell line. Then we put it in the mice. In the mice, we do really well. I'm pretty good at curing cancer in mice. But then the problem is you take it from the mouse into the person, and we are so complicated, and there's so much redundancy in every system, which is good, which is why we don't die when we're born, because we have ways around things. But the problem with that is our cancer is made from us, so it also has ways around it. So even if you block one particular pathway, your cancer can figure out another way to keep growing. And so when we take things from the mice into a really complicated person, things that worked in a simpler system don't work as well. And so you always have to keep looking at it and decide on what can we tweak, what can we make better. So right now, metformin as a single agent, at least in ovarian cancer, really hasn't shown a lot of promise. We're waiting on the results of it in endometrial cancer in combination with chemo, and that trial was stopped early because it probably looks like it wasn't helping there either. So right now, it hasn't panned out, but that's not to say that it might work better in combination with something else in another ramification of it. In terms of sugar, if you go online and say cancer prevention diet, cancer curing diet, you'll read all about don't ever touch a sugar molecule. I love chocolate, so it's really hard for me. But what I would say is that sugar is a very easy energy form, and so cancer use a lot of sugar. PET scans play on that with cancer cells picking up sugar molecules much more easily. But I would just say everything in moderation. I don't think anybody should go out and not have anything that has any type of sugar because of their fear of their cancer coming back or growing. The flip side of that is I think we should all eat much healthier, because the problem with a lot of sugar is it pushes up our insulin, which is a growth factor. So I think moderation is key. A lot of non-processed foods, a lot of vegetables, more the paleo Mediterranean type diet.
So there were a couple of questions related to the role of stem cells, and especially in persisting after chemotherapy, and that's a way of causing resistance. So, over the last 15 years, there's been a lot of work done in this area to figure out why do cancers survive, and why do they start to grow again after a period of time. So cancer stem cells are thought to be a small part of a larger cancer mass. So these are thought to be anywhere from about 0.5% to about maybe 2% of the overall cancer burden in a given patient. And given that these have stem cell type of features, they tend to be more resistant to chemotherapy, and that's why they tend to survive. Now, again, is a very different time in terms of trying to learn about these. So there are groups around the country, around the world, who are doing what's called single cell analyses, where they'll pick out literally single cells out of a larger tumor and then look at these in exquisite detail in terms of what their genetic makeup looks like, which ones might be these cancer stem cells, and how resistant are they. So there are some clues in terms of what makes them resistant, and now there are a couple of clinical trials that are being done. One using a drug called, or a drug against a protein called focal adhesion kinase, and then another against a target called ALDH, or aldehyde dehydrogenase. So fancy names, but whether or not these truly work to kill off cancer stem cells, we don't know quite yet. But the point I wanted to emphasize, though, is that our understanding and our ability to go after these kind of resistant cells is continuing to go up year by year. So there are, I think, unique opportunities emerging in that area. Amanda, there were several questions related to combination of Avastin with cyclophosphamide, and what role does this kind of therapy play, and why might this kind of treatment combine well, and so on?
So, as we've talked about, I think all three of us have talked about the role of combinatorial strategies, and in many cases, drugs like Avastin or the VEGF inhibitors work better when combined with another agent, because these drugs are usually more chemostatic. They don't necessarily promote significant tumor reduction, but when used in combination with a drug that can be can potentially generate a response in a tumor and cause either a partial shrinkage or a more complete shrinkage, it's more likely to be efficacious. Cyclophosphamide is an oral drug. It's very well tolerated, and so in women who maybe have had multiple lines of treatment but still have a good enough health and performance status to receive more treatment, may not have already seen Avastin or cyclophosphamide, it can be a very nice combination to consider that helps also preserve relative quality of life given the good side effect profile of that particular combination.
Susan, there's some questions broadly related to chemotherapy. Why did Taxol and platinum become first-line treatment after surgery? And then also, what role does intraperitoneal chemotherapy play?
Wait for those. All right. So why Taxol and platinum became first-line treatment is that in multiple years of multiple trials, they work the best, is the bottom line. And we keep trying to tweak it. So it kind of, the older you get, the more you've seen more things. So when I started my training, the frontline treatment for ovarian cancer was a platinum agent, cisplatin at that time, and cyclophosphamide. So that was our original first-line treatment in the 70s and the 80s. Then the paclitaxel taxane drugs came about and showed that they were far better than the Cytoxan, so it replaced that. And then we replaced cisplatin with carboplatin because of the side effect profile being that much better. So then we had this taxane platinum as the best upfront treatment, and ever since then, and I would say, mid-90s, we've been trying to improve that. We tried adding a third drug to those two, so Gemzar, topotecan, Doxil, those other second-line agents, and found that 3 drugs of those chemotherapy types did not improve over 2, but had no surprise or side effects. So then we went back to 2 drugs. Then we said, okay, well, if we add some of these other type agents, non-traditional chemo, but these, things like Avastin, other hormone type things, would that improve it better? And we can talk about Avastin in the upfront arena, about whether that is something we do or don't do in a maintenance therapy. And then the other question that was being asked simultaneous to adding other drugs and different drug combination was route of delivery. So we knew, if you put the drugs right in the abdomen, so intraperitoneal or IP therapy, that you get a higher drug level. Okay, so there've been 3 huge trials looking at intraperitoneal versus IV therapy, and all showed, with some caveats, probably that the IP was better. The IP therapy is tougher, more side effects. Only 40% of women on the most recent IP trial actually finished it IP because they just couldn't tolerate it, but even if you intended to treat them that way, they did better. Along the same time we were looking at IP, these other drugs were coming out in different schedules of giving Taxol weekly and all of that, and so it's really muddied the water in terms of, is it density of therapy? If you give more treatment and you get more IP or you get more weekly, is that better? Or is it the IP route that's better? Or is it the adding another targeted drug that's better? So these are the things we are still trying to tailor and work out. I use all of them in different scenarios. So for some patients, I might choose to do dose-dense Taxol. For some people, I might add Avastin in up front. For other people, I may choose a different thing besides the taxane because maybe they're diabetic and they have a horrific neuropathy already, and so I don't want to use that for that particular patient. So when you have 3 people up here telling you what they do, you're going to get 6 different answers for the most appropriate, because we'll each pick 2 for each patient. Because there's a lot of art to figuring out for a particular patient what is going to work best. And as I tell my patients, I really wish someone would give me the crystal ball that tells me what the right answer is, because we don't know until we've tried it. So.
This is again, a fairly broad question that I'll briefly answer. It relates to what's your most significant frustration or barrier with regard to advancing care or outcomes for women affected by ovarian cancer? I would say that it's really a lack of recognition, I think, at a broader level at the NIH, NCI, that ovarian cancer is such a diverse and deadly cancer. And I can't tell you how much what all of you do matters in terms of raising awareness at the policy, at the governmental level, and really would encourage you to continue to push hard for that. And every year, for the Department of Defense, they try to kill the funding for ovarian cancer research. I think all of you know this because it's because of you that kind of funding is able to be sustained actually every year. So I really applaud what all of you do, and I think the biggest frustration is the lack of funding for how deadly this cancer is. And in this day and age, research funding, it truly matters. It matters for making new advances. It matters for bringing new people into research. It matters for sustaining those who are already in the field for doing research. So there are many, many reasons why raising awareness around this disease and funding really does matter. So, Amanda, question for you. In a relapse setting, when CA-125 is rising, why are physicians reluctant to give some kind of treatment versus waiting till there's physical evidence of disease?
That's an excellent question. Yeah, empirically it would make sense, right, to just be aggressive and go ahead and start treating. And as surgeons and oncologists, we tend to be very radical, aggressive people who want to act definitively. However, there was a large clinical trial that was performed, a randomized trial that demonstrated that in women who received treatment up front in that setting and got the most aggressive forms of therapy compared to women who were just observed closely with rising CA-125 until imaging or clinical symptoms demonstrated definite evidence of disease. There was no difference in survival or outcome, and that floored a lot of us who were, just so eager to treat and act quickly. In fact, it just increased toxicities and worsened quality of life for a lot of women. And so it's important that I love that quote about science and hypothesis. We may think we know what's best, but in many cases when we actually study a question, we are constant students of this field and lifelong learners, and must adapt to the evolving science so that we can do our best for all of you and for all of the other women in the US and worldwide with ovarian and fallopian tube cancers. And quality of life, I think, is an incredibly important part of having meaningful survival. And so we want to help women not only live longer, but have the most meaningful life possible during that time.
That same study, just to give a number, because some people like numbers, none of us do, but the folks on that trial where we intervened early, we gave them chemotherapy early because it makes sense. You start it sooner, you get a better response. There was no difference in their survival, but they were on treatment 7 months longer. So the women that got intervened earlier got treatment for 7 months, and you, as everyone here has maybe been on treatment and know what that's like. So if you're trading 7 months of no treatment at all versus 7 months of treatment, but no difference in your outcome, I think most of us would probably, if we felt good, would rather not get treatment unless it's going to improve our outcomes. If it's going to improve our outcomes, all of us are willing to do pretty much anything.
Susan, a couple of broad questions. Are there specific foods to avoid in high-grade serous cancer? And second is, what research, again, a little bit of a different question, but what research is being done for platinum-resistant cancer?
I don't have a specific list of foods you can't eat. I have a specific list of foods you should eat, whatever you want. No, just kidding. I'm a big fan of dark chocolate and red wine. So, yeah, I know. And I don't have any endorsements from any of those people, but I was in Belgium, and I am super willing to be a spokesperson for chocolate. There's not one thing to avoid. What I will say, just as a caveat to that, are supplements. And we talked about grapefruit juice earlier. There are some particular drugs that can, or foods that can impact how drugs are metabolized. So if you're doing any type of supplement type stuff, or you decided to go on a radical grapefruit only diet, that's something you should talk to your physician about, because that could impact treatment. In terms of healthy foods, I really do like some of the superfoods, all the, I can't say it very well, cruciferous vegetables. And we actually have a couple studies ongoing, the GOG Lives or Lives trial. We can't decide which way it's supposed to be. I call it Lives, which is really focusing on reducing fat and increasing intakes of the 6 colorful vegetables a day, and also adding exercise. I'm a huge exercise proponent in terms of improving quality of life, potentially decreasing recurrence. So I would encourage you to eat lots of cruciferous vegetables, exercise every day, even if it's just 3 10-minute walks. It really makes a huge difference in terms of quality of life. And was there another thing I was supposed to answer?
What research is being done around platinum-resistant?
Lots. We have this category, platinum-resistant versus platinum-sensitive, but we kind of combine them all together. So there's a ton of research going on in that. It's the hardest group to study, because the problem is the cancers that get to be platinum-resistant are the most resistant to everything that we do. So it's much harder to show that something's working or not working. So a lot of times we might start some of the research in a more platinum sensitive, so we can see if there's a signal, okay? Because you don't want to abandon a drug that might have some utility. So you usually start off trying to look at where it has the best opportunity of working. Then you might rotate that into the hardest group of women to treat, which are the platinum resistant. So there's a ton of research going on, and I will echo what was said earlier. It really matters. Lobbying for government funding, but also I know many of you are involved in grassroots fundraising. Those make a huge difference. We have funded a lot of our research out of our local groups that have come together and helped us support our tampon study. They've helped us support our clinical research infrastructure. So even if it does not seem like much, local efforts really matter. And I know we've all benefited from our local support.
There were 5 questions related to clinical trials, how to find out information about trials and importance of clinical trials and so on. So I'll briefly talk about that part, and if the others want to add in, certainly feel free. So clinical trials is really are how we make advances and how we bring about new treatments. So there was a question about Taxol and platinum, how that came to be as first-line treatment. Well, in the 1990s, there were a number of series of trials done that compared Taxol and platinum to the old regimens, which used Cytoxan and platinum, and showed that addition of Taxol was better. Then there were a series of clinical trials that looked at how do you give the Taxol and whether the dose intensity matters and so on. So the point being, not to dwell on that particular set of trials, but the point being that that's really how advances are made and how new treatments can come to be available for women with ovarian and other cancers. One specific point that I do want to make around the importance of trials is that some of the government entities, such as FDA, that approves clinical trials or a given type of treatment, historically has required overall survival as an endpoint for many of the trials, which for a disease like ovarian cancer is not necessarily a good endpoint to look at for many reasons. Among those being that even in second, third, fourth line settings, you can still see responses that can be quite meaningful. So over the last 3 years, we've held a series of meetings between gynecologic oncology community and the FDA, with the last meeting being about a month ago. And these have been incredibly impactful because the last many FDA approvals have come from not overall survival at all, but rather looking at response rates or progression-free survival as an endpoint. So this kind of dialogue between the communities and the government entities is incredibly important so that we can make advances. One other aspect that was asked was, how do you find out about clinical trials? There is a national database called clinicaltrials.gov where all clinical trials have to be registered. That is a central repository where any patient with cancer can find out availability of clinical trials. And there were also questions whether you rely on the oncologist you're working with and so on. I say that obviously work with your oncologist and physician, but also be an advocate for yourself and look up other opportunities for clinical trials. I never take any issue with if someone wants to get a second opinion and so on regarding their care. I encourage it. There's benefit in doing that, and you find out about what else might be available. In clinical trials, we really try to design for all phases of someone's care, and again, so that we can continue to make improvements really at the entire spectrum, all the way ranging from initial diagnosis to treatment to surgery to chemotherapy, new therapies, and even survivorship issues can certainly be addressed under clinical trials. Anything? Sure.
I think we both wanted to add a little. I think there are a lot of myths surrounding clinical trials that I know all of us speak to our patients about, and maybe you have had concerns about too. And one of them is that, am I taking a big risk in my life and becoming a guinea pig, if you will, or not going with a standard approach? But the reality is, across multiple different tumor types in men and women, that folks who go on clinical trials have better overall survival than those who don't. That's been studied in many different settings. And we don't know why exactly, whether it's that you're being treated at expert centers by expert oncologists, whether it's that you are getting the opportunity to get standard treatments plus the addition of the newer, sexier, more promising drugs that are coming down the pike. It's not clear, but it has been seen consistently. And the second thing is that probably 70 to 75% of the clinical trials available for women with ovarian cancer are not offering women purely experimental options. It's usually a standard treatment with the addition of a more experimental option. So the opportunity to see, we know this works, but we want to see if we add something else to this or try this in a different combinational strategy, will we get a better response and a better outcome for women? And so, a trial isn't always right for a woman in a given point of time in her treatment, but really want to encourage women and families to please consider clinical trials when the time is right, because it does actually can lead to improved outcome in that individual woman, and it really increases our knowledge to understand how to best improve cancer outcomes in general.
The other thing I will say is all of us have clinical trials open, but not all of us have the same ones. So I very frequently, I'm in Charlottesville, it's 3 hours from Hopkins, it is 2 and 3 hours from Duke. So I have my little cadre, and I know kind of what other folks may or may not have open too, so that if I don't have something, but I think this patient might be open for it, I'm really happy to have them go someplace else if that's feasible for them. You can go online and look yourself, clinicaltrials.gov, it's wide open, everyone can look, but it becomes overwhelming as a patient to look at that and go, oh my God, I have no idea if I qualify. So you can use your oncologist to kind of help sort through things. And I love it when I have my patient come in and she's got 5 printouts. I'm like, oh, okay. And sometimes I can very quickly say, no, you don't qualify for this one might be a good option, this is why I wouldn't do this for you, or something like that. So it's really good to look at those things, and I'm thrilled to have my patients go someplace else. I like to steer them to a place that I know really takes trials seriously. One thing you'll know, if you Google anything with cancer, you'll find all of these things that when you look on a website, and let's just say it's called integrative therapeutics, and that they say that they can cure cancer, and look at our testimonials. If you see something that says testimonials, that's not science. Okay, they're not doing a randomized controlled trial. They're just simply saying this works. Okay, so just really look at that, and all of us want to work with you. We're not trying to hide anything, okay? I'm open to marijuana, I'm open to whatever, but just do work with your physicians to try and make sure that you get the best care and you don't get taken advantage of. What I tell my patients is, if they're charging you $40,000 and insurance won't cover it, let's think long and hard about whether this is a good option if it's free.
So OCRFA also has a clinical trial matching service as well, so just an important tool for you to be aware of.
What's the website?
No,
seriously,
they'll make that available.
Well, we should. I need it too.
Amanda, what's the status of the Cancer-Seek test and liquid biopsy at Hopkins?
Thank you. I'm very fortunate to be part of a research team, and we're going to be talking about this a little more in my session, studying how we can potentially detect or screen for ovarian and 12 other solid tumors at an earlier stage or precancerous stage, or how we can detect these tumors at recurrence in a more meaningful fashion. And the Cancer-Seek is a test in which we take a sample of blood, a plasma from a patient, and instead of looking for actual cancer cells, we're looking at genetic material from cancer cells, so little DNA fragments, and looking specifically at mutations that we know are common in specific types of cancers like ovarian cancer. And ovarian cancer and many other cancers go through an evolution. They go through a growth phase, they divide, and then these cells eventually die, whether by treatment or just they've gone through their natural life cycle. And when they die, the cells can go through a process called apoptosis, where they basically burst and die and release their inner contents into the bloodstream. And so we're looking at detecting those little DNA fragments that have the ovarian cancer mutations within them, as well as cancer mutations from many other tumors, to serve as a potential tool for detection and screening in this population. We've just published our latest proof of concept study in the journal Science Translational Medicine, which I'll talk about a little more in our session, looking at the success of the Cancer-Seek in terms of identifying these mutations. And we're detecting really teeny tiny fragments of DNA here. So it's a test that's under great evolution and is going a significant amount of sensitivity analysis and refinement. But we're doing the same thing in what are called the pap smears of these patients if they have a uterus, and using a special tool, like looks like a little pipe cleaner actually, called a tau brush, to also try to detect these DNA fragments within the vaginas or uteruses of women. So more on that in the next session.
Susan, some specific questions about genetic testing. Is genetic testing normally covered by insurance, and is it covered by Medicare? And then there were some questions related to, can you test children for BRCA mutation before age 18? Or there were some also questions broadly about what's the right age or time for genetic testing.
Okay. Damn, I should have written it down.
So the first question being, is it covered by
Yes,
insurance
okay.
and Medicare?
So
and then the age of testing.
All right, so insurance, yes, pretty much the national guidelines are any woman with an epithelial ovarian cancer, the insurance should pay for genetic testing. Medicare does pay for genetic testing in women who have ovarian cancer. They also pay for certain other groups of women. They do not pay, Medicare does not pay for genetic testing in women without cancer. Women without cancer can undergo genetic testing, and again, it's most often covered by insurance. Insurance is not stupid. They're in it to make money, okay? And so, and more power to them, but they know that if they can identify women that are high risk and prevent a cancer, that saves money, okay? Because if you prevent cancer, you never have to go through surgery, you never have to go through chemotherapy and surgery. So they actually, both because I think it's the right thing to do, but also because it makes financial sense, do try and test appropriate women. In terms of age at genetic testing, it's a really hard thing. If anybody's ever seen, there's a documentary called In the Family, by a woman named Joanna Rudnick, who herself is a BRCA carrier, and it explores, it's about 10 years old, but you can get it on Netflix. It explores all of these kind of social things about what do you do if you find out you have a BRCA mutation at 20? I mean, that's a lot to carry, and so in my view, the age to test is when it's going to make a difference. And that is hard. If I were a mother and I had a BRCA mutation and I have 2 daughters, would I secretly want to know right away if they carried that gene? Yes, okay, but do they need to know? Probably not. And when would we do something different? At 25, we might start breast MRIs for breast cancer. We might start birth control pills. So you don't really want to get that information until it's going to change your management, okay? So for right now, we do not recommend doing genetic or cancer genetic testing for women under 18. Can you get it if you want it? Probably, but I really would, that's when you have to have a really good conversation with the patient, the family, genetic counselors about what the end game is. And again, we're going to go through all of that stuff and more in my session.
There were some questions related to biology of ovarian cancer, and these relate to how cancer spreads and what our understanding is of spread to the lymph nodes and so on specifically. So just a brief answer around that. Historically, we used to all think that ovarian cancer only spreads by coming off of the actual ovarian tumor and then spreading from surface to surface, meaning implanting in other places within the belly and pelvis. Well, it turns out that ovarian cancer can indeed spread through the blood as well. There have been now several studies that have shown that ovarian cancer cells are indeed present in the blood system as well. We know that it can go outside of the belly to lungs, and less commonly to the brain and other places as well. Even when it travels through the blood, it seems to have a particular preference for growing within the belly, meaning growing on the fatty apron, the omentum, or some of the other tissues within the belly. If you remove lymph node samples for women with advanced ovarian cancer, about 2/3 of the women will have positive lymph nodes. So it can clearly go to the lymph nodes. There's a lot of work being done now to try to understand how does it get to the lymph nodes, and when cancer is spread to the lymph nodes, does it still respond the same way when it's there compared to in other places and so on. So it's a very active area of research in terms of understanding how ovarian cancer gets to these places and whether the responses are similar or how else we can treat some of these spots even better than in the past. Some of this is obviously early work still. Amanda, the couple of questions related to testing in terms of can you do testing from cancer slides that exist from someone's tissue, and how can that information be used?
Yeah, so a lot of centers now are doing in-house testing to look at protein or molecular or genetic differences in a tumor that might allow that tumor to be treated in a very specific way. Dr. Sood, Anil already sort of mentioned some of the testing that we're doing for immunotherapeutic purposes. So we're looking at something called microsatellite instability or genetic alterations in some of the DNA of tumors that make them more susceptible to immunotherapies. And so we're routinely at Hopkins, and I'm sure at UVA and Anderson as well, testing, all endometrial cancers, and in the ovarian cancers, especially the endometrioid subtypes, for these particular alterations, because now we have an FDA-approved treatment for that. We also do a lot of in-house or testing, or we might send out for genomic sequencing to look at a variety of mutations that are what are called actionable, that we have a known drug or target that we can utilize if a patient has a specific mutation. And we typically do that at Hopkins in the setting of cancer recurrence, or in the setting of a rare tumor where we may not know the very best treatment strategy in that patient and want to really tailor or individualize, and that's called personalized medicine. But I think institutions are handling this very differently, and it's, but the more tailored that medicine becomes, the more we're likely to see these types of tests used both at institutions and then send out tests as well.
So there were a series of questions related to side effects from Avastin. Some of these are very personal questions, so I'm going to try to frame these broadly. That if you have someone who has high blood pressure that's not being controlled with antihypertension medications, what can be done when they are on Avastin? And if they continue to have side effects from Avastin, what are the alternatives?
We have to have the blood pressure under control. It's no good to treat you for something for ovarian cancer when you end up with a big stroke. Okay, so there are some patients that just, even with our best antihypertensive, we can't keep them on Avastin, and so we may use something else that can target the antiangiogenic series. And so I usually work very closely with their primary care doctor or our internal medicine colleagues to see if we can get it under control, but you have to get it under control.
Boy, the time just flies by. My only regret is that I didn't get through some of the other questions and so on. But as we finish up here, I really want to thank all of you for coming to this session. And I want to thank Amanda and Susan for taking part in this panel discussion. And we'll be happy to stick around for some time afterwards as well, if we can answer some specific questions and so on. Thank you again.